Liddle syndrome is an genetic disorder, renal disease condition. Look at this picture shows that nephron and kidneys. Look at this detail going on. Introduction. Liddle syndrome is a rare genetic disorder that affects the kidneys, leading to severe hypertension and electrolyte imbalances at a young age. It is a form of monogenic hypertension, meaning it results from a mutation in a single gene. Despite the similarity in symptoms, it is not related to aldosterone excess, differentiating it from other type of hypertension. A definition: Liddle syndrome, also known as pseudo aldosteronism, is a autosomal dominant genetic disorder characterized by increased renal tubular reabsorption of sodium and water due to a gain of function mutation in the epithelial sodium channel. This leads to hypertension, hypokalemia, low potassium, metabolic alkalosis, and suppressed plasma renin and aldosterone levels. Etymology: the term Liddle syndrome is named after Dr. Grant Liddle, the American endocrinologist who first described the condition in 1963. The word syndrome comes from the Greek syndrome, meaning a running together, referring to a group of symptoms that constantly occur together. Epidemiology: Liddle syndrome is a rare genetic disorder with a estimated prevalence of less than 1 in 1 million people worldwide. It often goes underdiagnosed due to its clinical similarity to more common form of hypertension, especially in young individuals. Types: there are no officially classified subtypes of Liddle syndrome. However, it may vary based on the specific gene mutation. involved. 1. SCNN1A mutation affects the alpha subunit of ENAC. 2. SCNNOB mutation affects beta subunit. 3. SCNN1G mutation affects the gamma subunit. All result in increased ENAC activity and similar clinical manifestations. Causes: Liddle syndrome is caused by mutations in the SCNN1B or SCNN1G genes, which encode the beta and gamma subunits of the epithelial sodium channel in the distal nephron. These mutations leads to 1. Increased sodium reabsorption. 2. Water retention. 3. Increased blood volume and pressure. 4. Suppression of renin and aldosterone production. Risk factors: 1. Genetic inheritance. Autosomal dominant. A single copy of the mutated gene from either parents is enough to cause the disorder. 2. Family history of early onset hypertension. 3. Consanguineous marriages increase chances of inherited rare diseases. Complications: if untreated, Liddle syndrome can lead to 1. Early onset severe hypertension. 2. Stroke. 3. Hypertensive heart diseases. 4. Left ventricle hypertrophy. 5. Chronic kidney diseases. 6. Electrolyte imbalance complications like cardiac arrhythmias from hypokalemia. Pathophysiology. Pathophysiology of Liddle syndrome step-by-step process. 1. Genetic mutation. A mutation occurs in either the SCNN1B or SCNN1G gene, which encodes the beta or gamma subunit of the epithelial sodium channel ENAC in the distal convoluted tubule and collecting ducts of the kidney. 2. Increased ENAC activity. The mutation leads to gain of function by preventing the degradation of ENAC proteins, resulting in their prolonged presence and increased activity of the renal tubular cell membrane. 3. Excessive sodium reabsorption. Overactive ENAC channels cause excessive sodium reabsorption from the renal tubule into the bloodstream. 4. Water retention and volume expansion. Sodium reabsorption is followed by water reabsorption, leading to expanded extracellular fluid volumes and increased blood pressure. Hypertension. 5. Suppressed renin angiotensin. Aldosterone symptom or AAS due to volume expansion and high blood pressure, the body downregulates the RAAS system, causing low plasma renin activity and low aldosterone levels. 6. Potassium and hydrogen ion secretion to maintain electrical neutrality. The kidneys increase potassium and hydrogen ion excretion, leading to hypokalemia and metabolic alkalosis, respectively. 7. Clinical manifestations. The physiological effects manifest as early onset hypertension, hypokalemia, metabolic alkalosis, and suppressed renin and aldosterone despite the absence of excess aldosterone. This mechanism makes LIDDLE syndrome a form of pseudo aldosteronism, where aldosterone like effects occur without elevated aldosterone levels. Signs and symptoms. 1. Early onset hypertension, often before age 20. 2. Fatigue, muscle weakness due to hypokalemia. 3. Polyuria and polydipsia. 4. Metabolic alkalosis symptoms, confusion, muscle twitching. 5. Arrhythmias. 6. Growth retardation in children. Diagnosis. 1. Family history of early onset hypertension. 2. Blood test. A. Serum potassium for hypokalemia. B. Plasma renin activity. C. Aldosterone levels. D. Blood pH, metabolic alkalosis. 3. Genetic testing to confirm mutations in SCNN1B or SCNN1G. 4. 24 hours urine, sodium and potassium. 5. Blood pressure monitoring. Nursing diagnosis. 1. Risk of electrolyte imbalance related to renal tubular dysfunction. 2. Ineffective health maintenance related to lack of knowledge about a rare genetic condition. 3. Risk for decreased cardiac output related to arrhythmias from hypokalemia. 4. Anxiety related to diagnosis of chronic genetic disorder. 5. Fatigue related to electrolyte imbalance. Medical management. 1. Potassium sparing diuretics that block ENAC. 2. Avoid aldosterone antagonist. Ineffective because aldosterone is already low. 3. Low sodium diet to help control blood pressure. 4. Antihypertensive therapy if necessary in addition to amyloid. 5. Regular electrolyte monitoring. Nursing management. 1. Monitor vital signs, especially blood pressure. 2. Monitor serum electrolytes, potassium and sodium. 3. Educate patient and family on lifelong nature of condition. 4. Encourage low sodium diet. 5. Promote adherence to medication. 6. Provide psychosocial support due to the chronic genetic nature. Treatment options. 1. Amyloid directly inhibit ENAC and reduce sodium reabsorption. 2. Low sodium diet to reduce volume over lodomelis. 3. Antihypertensive agents if additional BP control needed. 4. Potassium supplements if hypokalemia persists. 5. Genetic counseling for affected families. Psychosocial medicine. 1. Genetic counseling to help families understand inheritance and future risk. 2. Support groups connect with others dealing with rare genetic hypertension. 3. Education program focused on lifestyle changes, medication adherence, and diet. 4. Family counseling to support parents and children coping with chronic illness. 5. School based interventions for children to manage medical needs and reduce stigma. Prevention. 1. No known method to prevent genetic mutation. 2. Genetic counseling for a risk families. 3. Early diagnosis through family screening. 4. Pre-implantation genetic diagnosis PGD during IVF for known carriers. 5. Regular monitoring of blood pressure in children of affected individuals. In conclusion, Liddle syndrome, although rare, is a potentially severe form of monogenic hypertension that can lead to life threatening complications if undiagnosed or untreated. It highlights the importance of early recognition, family screening, genetic testing, and specific treatment with ENAC inhibitors like amyloid. With appropriate management, individuals with LIDDLE syndrome can live healthy lives. Lifelong follow up, patient education, and psychosocial support are critical elements of care. Thank you. Have a nice day.